This conference will now be recorded.
Okay, so let me actually change my layout really quick. Okay, so we have two CT scans on this patient. These were done about a month apart. And this is a patient who has a history of lung cancer um, and was presenting to the emergency room with some new symptoms. And so we got this CT. Obviously, they've got pleural effusion, which has gotten worse. But the interesting or cute finding that I think we don't see all that often is kind of a corner shot on this one, which is if you look at the thyroid gland on the current exam here, on image left compared to a month prior, you can see it's like tripled in size and is really heterogeneously enhancing. So this I thought was a good look for acute thyroiditis, which panned out their thyroid hormone levels were really abnormal. And this was thought in this particular patient to be due to their their therapy with pembrolizumab. So it was thought to be a drug reaction related to pembrolizumab, but just a nice CT example of acute thyroiditis.
And how long? What was the time frame between the two?
These were, sorry, hold on one sec. Sorry, I said 2 months. These are actually a month apart, these two
Okay.
CTs. Yeah.
And to your knowledge, does the immune-related thyroiditis, is it like an early manifestation, or can it happen at any time along the treatment?
That's a
I've
great
never
question.
seen it, so.
Yeah, I had never seen it. And again, like this is just, I'm going off of the notes that they were associating it
Hmm.
with this drug, but it seemed like the patient had been on the drug for quite a while. So I don't think it was like an initial therapy. They had been on it for quite a while and they were taken off of it, I think, after this.
Okay.
Um, but yeah, it's just an unusual manifestation. All right, the next one that I have is this patient here. So this is a patient who we can see from this chest x-ray. They've got a sternotomy plate as well as these little looped wires. So this configuration is suggestive of a prior lung transplant, which is what this patient had. This CT was actually done about a month after their lung transplant. And I thought just demonstrated a really nice finding that we do see occasionally after lung transplant, which is you see a lot of septal thickening as well as these sort of more nodular um, or nodules along the interlobular septae. So, you know, in a different patient, you might be worried that this is like malignancy involving the interstitium or the lymphatics, but this is actually a really dramatic example, but not an uncommon finding that we see post lung transplant, which are lymphatic pearls. And these are just sort of collections of lymph fluid along the interstitium. And that happens because when surgeons do lung transplants, obviously they reconnect the airways, they reconnect the blood vessels, but they do not reconnect the lymphatics because obviously that would be very difficult and tricky to do. And so while the lymphatics are sort of figuring themselves out and trying to create new drainage pathways, you can get this, in some cases like this, very dramatic backup of lymph fluid into the interlobular septae, and they can sort of pool in these little pearls. So this is just
Very
the most
cool. Yeah,
dramatic example I've seen of this.
we've seen a couple of nice cases of these lymphatic pearls, and yeah, it's important to recognize them because it doesn't mean lymphangitic spread of tumor, and it doesn't mean they're
Hmm.
nodules. They're just dilated channels.
Yeah,
I've heard them called lymphatic lakes, all
yeah,
different.
I love it.
And how
All right,
far out
and
from transplant was that? Because we usually hopefully don't get CTs that early on in the because usually this reperfusion edema in most patients is gone within a few days.
mhm. This one was actually um, I think this was about 2.5 months after transplant. This was actually a redo transplant. This was their second set of lungs. So
Hmm.
yeah, it was a couple months after the redo transplant that we got this image.
Well, how do we
And I
know
think it,
that these aren't veins or venules that are dilated? Because
well, that's a good question.
So
Um,
I thought you were going to say when you first showed that these were venous lakes. Um, so and then I would worry about whether the pulmonary veins were compromised
hmm.
in the transplant. Do they look widely patent and stuff like
Yeah,
that?
they look pretty good to me. There's maybe very slight narrowing there, but otherwise the veins look pretty wide open. And we did, again, this patient came in with, I think, acute symptoms, which is why we gave contrast. We usually don't give contrast for follow-up lung transplant patients, but we did in this case, and I think the veins look pretty wide open in this
Okay,
particular patient.
yeah, that's
Yeah,
cool.
yeah. All right, and then one last one, just because we're getting towards the time when we have new residents on call. So this is, I thought, a nice example of something that can be a relatively subtle finding on radiograph, but is important to pick up. So this is a patient who obviously had a prior sternotomy, and these two radiographs were taken 1 month apart from one another. So on this prior one, we can see this is immediately post-op. They have a surgical drain in place, as well as their sternotomy wires and some surgical clips along the left side of the mediastinum. So this is a patient who had a cabbage. And a month later, they show up in the emergency room with chest pain. And the thing to really take note of between these two radiographs is how the sternotomy wires are in different orientation than they were a month ago. We can see that there's one at least that's completely flipped horizontal. The bottommost one has sort of dropped a lot further than it used to be. So this is a really good radiographic finding of sternal dehiscence. And this is a good time course for it, right? It usually happens in this sort of time course, a month or so, within a month or so after surgery. And this patient did go on to get a CT that same day. And we can see that there's a lot of fluid sort of separating these two sternal hemifragments. And we can see some of those wires are just sort of sitting in that space between the sternal hemifragments. So good look for sternal dehiscence. And in this case, the skin has separated as well, but the skin doesn't always necessarily separate in these cases. So sometimes radiographically, we can pick it up before they necessarily see it visually on physical exam. So just noticing the difference in positioning
Wow,
of those wires.
there's a big
Very
hole
good
in this
example.
person's chest.
Yeah,
Yeah,
it's a very big hole in the chest. This person went and got washed out and reattached. So they're doing okay. But yeah, good example of how they've moved.
Oof.
Mm-hmm. All right,
All
and those are
right.
my cases.
Thank you, Maya.
Thank
David, are you
you.
ready or you want me to go?
I'm ready.
All right. Let's see, where are you? There we
Let's see, I'm going to share the entire screen, okay? So I hope you can see a CT scan,
Yep.
Yep.
okay? So this person has two flavors of fat in the chest. So I don't have a plain radiograph here, so let me give you the coronal here. For one thing, there's this big fat collection here at the left base, and it turns out there's a hole in the diaphragm. You can see some surgical tracks nearby. This person had had surgery for endometriosis, so I think they were probably picking off little deposits near the diaphragm and created a hole thereby. And so this is abdominal fat, peritoneal fat that has gotten into the lower thorax. But there are other fat collections here in this chest too. Last week or the week before, I showed a case of lipoid pneumonia, and this is another case of lipoid pneumonia. So let me show you that in cross section. This person has these fat deposits here in the right mid lung and the left lower lung, and I think the right lower lung as well. Down here we have maybe a smaller collection down there. So this person had bowel problems and was probably taking mineral oil and has these exogenous lipoid collections here in the chest, this low attenuation fat density in the chest from aspirated mineral oil. And if you look at the esophagus, you can see this esophagus is not doing a great job. It does have a fluid level in it, so this esophagus is always probably delivering potential aspirational fluid to both lungs here. Okay, so we have two kinds of fat. We have herniated fat from the abdomen, and then we have exogenous fat from mineral oil. And this person has an abnormal chest radiograph with diffuse lung disease, and you can barely see that there's a nodular component to it, a fine nodular component, which actually gets a little bit clearer as we go here. So a few days later, I think the nodules are emerging. And then on this one, we really have very fine nodules throughout both lungs. And you will not be surprised to hear that this is a miliary pattern here. Very fine nodules here on confirmed on CT. This is miliary tuberculosis. And I don't know the clinical setting right now for this extensive TB. This person probably also has intestinal involvement because a lot of the symptoms were abdominal in this person, including blood per rectum. So miliary tuberculosis, and let's see if I have the MIPS to bring this out. Yeah, you can see the snowstorm of fine nodules here in miliary TB. We had a very similar case this morning, which I haven't captured yet, which was miliary metastasis from a lung adenocarcinoma. But miliary pattern means that it's blood-borne. It's in the bloodstream delivered to the lung, and tumor cells can do that as well as infectious organisms like tuberculosis. So it's not surprising that you get a miliary pattern from metastasis. And then okay, this person has an interesting pattern of atherosclerosis. We saw a couple of cases of this a few years ago. Travis identified this pattern of atherosclerosis where you get these intraluminal components of atherosclerotic debris, these frond-like things, as coral reef aorta. And so this usually accompanies advanced atherosclerosis, often with peripheral vascular disease. And it has an atherosclerotic distribution, which means it's most common in the abdominal aorta. But if it's seen in the chest, it's usually in descending aorta. This person it's in the upper abdomen here, which is per usual. So these people often have peripheral vascular disease as well, severe claudication and things like that. So this pattern of frond-like protrusions into the lumen is very confusing. When I first encountered it, I thought we were dealing with an aortic tumor that had calcified just because it went deep into the aortic lumen. It wasn't just in the wall. But this is coral reef aorta. Travis knew about this entity, and that corresponds perfectly to this case and the cases that we showed a couple of years ago. I don't have images farther down to see if there was any peripheral component of this severe atherosclerosis. Okay, and then this person had several adventures with an axillary intra-aortic balloon. So the clinicians really seem to prefer this approach, but it seems to be fraught with difficulties from just following serial radiographs on these people. So here's the introducer carrying this left axillary intra-aortic balloon, and here's the proximal marker, which is too high. It's above the aortic arch, so you don't want to blow up this big balloon in the subclavian artery. That would be an awkward thing to do. It would damage the artery. So you want this marker to be, say, at the lower aspect of the aortic arch down here, about 3 centimeters from the top. Then you know that the balloon is going to be blowing up where the lumen is nice and big in the aorta. And here's the tip of this intra-aortic balloon. Remember, it's upside down because it was put in from the axilla, so the tip is actually down here. It's slightly across the midline. And then, on various radiographs, you can see that this thing slips around a little bit. So that's the problem with the left axillary approach or the right axillary approach, is that it's very easy to have the catheter slide in and out. And so here it's in a lower position. This actually seems more favorable. But let's look at the abdominal aorta in this person. And we can, let's find the balloon up high. So here we are. Here's the introducer part, and there's the tip, introducer, and then the top of this thing is here at this point. There it is. There's the marker. Then we kind of lose it. It's very hard to see unless it gets inflated. So a little bit while later in the abdominal aorta, it's beginning to be inflated. Now at this point, there's some gas in the balloon and we can see where it is. And so it's inflated at this point. You can see by its caliber that you don't want this blowing up in your subclavian artery. It's fine for aortas, but not for subclavian arteries. And let's follow this catheter. Here's the tip in the superior mesenteric artery. So another problem that these axillary intra-aortic balloons have is that you can't. It's hard to regulate the tip, and here that you don't want this tip getting out in a small abdominal artery such as a superior mesenteric artery. So once again, you can damage the artery if the balloon inflates in this narrow artery. That's not a good thing at all. So this thing belongs in the descending aorta. It does not belong in this branch. So the first time I've seen this particular complication of axillary intra-aortic balloon getting into a mesenteric or small abdominal artery. Have you guys had a lot of experience with these axillary intra-aortic balloons? I think it's easier for the patient. Patient can walk around and so forth.
I've seen a few, but then they still
Yeah.
seem to do more femoral ones.
Yeah, same with
So
us. They tend to do more femoral as well.
yeah,
Yeah.
it's interesting. In our pulmonary fellows conference today, they showed a case from like a year or so ago, but I'd never heard of this before. But one of the patients, the balloon pump overheated. They had to like turn it down or turn it off. Have you ever heard of that before?
No, the balloon itself and
No.
the
Or
balloon
the device. I don't know if it's the balloon itself or maybe the wires that run on it, but
or the pump.
they had one that was overheating.
It's interesting. You know, the gas that they use in this is helium. You'd think they would use you'd want something that was soluble in blood in
Right.
case it
Why don't they
ruptured.
use saline?
What they do not use saline. They use gas.
Right.
So
Why would they use gas? Is it with saline take longer to inflate the balloon?
yeah, it's a lot more viscous than
Mm-hmm.
helium. Helium is actually very favorable because it's the not very viscous at all. So
Mm-hmm.
it's less viscous than other gases. So it's really easy to ram it in and suck it back out every 60 times a minute. It would be very hard to move saline through the narrow feeding
Yeah.
tube and inflate it that way. So that's not going to work. So
Yeah.
they use a gas and they specifically use helium. Now you would not want to use air because don't want to create a bolus of nitrogen just insoluble in case the balloon ruptures. So helium is relatively soluble, so that is favorable in that reason. It's also
Right.
favorable because it's the least viscous gas.
Right.
So
And it's inert.
yeah, okay,
Cool. All
those
right.
are yeah.
Yeah. Okay. I can show. I have three I can share. All right. So you see my CT scan here?
I see your main screen. Yes, I do see yours. No, I don't see your CT.
Yeah, I don't either.
That is very odd. All right. Let's try this again. How about
Here we
now?
go. More
There we
better.
go.
All right.
Yep.
Sometimes you just have to start and stop. Okay, so this is a cool case. So this patient presented for ILD evaluation, and you can see there's a lot of abnormal looking lung. And so the first thing you'll notice there's fibrosis, there's reticulation, there's some traction bronchiectasis distortion. There's a background of mosaic attenuation. We have lots of lobules here that are hyperinflated. But then what I also want to point out is if you look very carefully, there's all these tiny tree and bud-like nodules hiding amongst all the fibrosis. You can see them, I think, best down in the lower lobes, just kind of tucked in there a little bit. A couple little solid nodules there. So ignoring those, this is a good look for a fibrotic HP. That fibrosis is peripheral, central. In this case, it's asymmetric, which is was very common. There's nice mosaic attenuation with hyperinflated lobules. And then we've got this tree and bud. So that usually suggests infection. You might think of mycobacteria if the patient was chronic or maybe something acute. So this patient came from the outside, but luckily, well, I don't think, yeah. Anyway, they did a surgical biopsy out in the outside several years ago. And it showed findings that are, pathologic findings that would be typical of fibrotic HP, the usual stuff. But they also identified acid-fast bacilli, and ultimately were able to identify Mycobacterium avium complex in the lungs. And so this patient had exposures to a hot tub. So this is hot tub lung, with the actual organism in the lungs. And I think it's not just the incident. The ones I've seen have always sort of looked like HP. And oh, by the way, there's the story or there's some findings. But in this case, I think the tree and bud is actually like a real infection. And there's been a debate: is hot tub lung an infection with HP, or is it just the organisms hanging out there? And there is some differences histologically with where the granulomata are and some of the inflammation. But this patient actually had enough organisms they were able to identify it on a biopsy specimen. So this is how he came to us after this diagnosis. But I think it's the first time I've seen a hot tub lung with real good nodules as well. So
Wow.
I can make a
Yeah,
mitt, maybe see him a little better. Yeah, there you go. You can see them.
nice.
They're just hiding in the fibrosis. See a few of them down low, but most of them are in that left upper lobe. So that was kind of cool. This next case, I'm curious what you all think. So I can't remember what this was. This is an old case I filed away just to come back to, and I never have seen anything afterwards. But I think this patient got scanned for some cough or something, and then you'll see there's this kind of funny cystic looking spaces here in the right lower lobe. Kind of wonder if that's bronchiectasis. Is there a sequestration down there? And you can see the airways are next to it. I'll make it even bigger. And really, I mean, other than this one little airway here, not much connects to this space. But what is interesting is you can see these sizable osteophytes right there. And then you don't see it, the abnormality anywhere else except where these osteophytes are. As I go down, you can see the biggest one's there, and it's got the most abnormality. And then it's kind of socked in here. So there very well may be some bronchiectasis down there. But I was kind of wondering if this is just all sort of, we see scar down there. We've seen some cystic spaces. If this is just a complex space related to these osteophytes, maybe got infected at some point. But it doesn't seem to be in continuity that much with the rest of the airways, and this smooth margin around it made me wonder if that's all this is. And I can put it up on a coronal too, see what you guys think. I mean, it's just weird to be following an airway because it's at multiple airway levels.
Yeah, I agree. It's unusual. I don't think I've seen, I mean, obviously, as you said, we see periosteophyte fibrosis fairly
Mm-hmm.
commonly, but I've not seen it with these associated bronchiectatic airway.
Right. And I've
Yeah.
seen traction bronchiectasis in there, but this is like
Hmm.
beyond that. But I wonder
Yeah.
if that's what this is, and it just maybe it did get infected at some point and
Yeah, and
scarred
then
down.
dilated
It
because
just
of that. Yeah.
yeah, it just seems too clean to me not to be. So anyway, it's just kind of a curiosity that I finally got around to putting together here. And then this last case is kind of the most interesting. So this patient was referred to our IR group for treatment of a pulmonary AVM. Unfortunately, she never went and got her bubble echo, which she was supposed to have done. And the interventional radiologist came and reviewed this. And you can see if we look in the right upper lobe, there's this big vessel here. There's some bronchiectasis. And then there's sort of all these funny looking vessels here. And then there's another big one that comes down here. Now, I will point out, if you look carefully, there's no hypovascularity, and we don't see any like tortuous vessel that we typically see like feeding these AVMs. So if you go back, if we start looking at this, we realize that let's go to this top vessel here. If we follow it back carefully, it's going to bring us right here. I should probably go to an angiographic window. Let's try that, make it a little easier to see. If we keep following back, there's the artery here, but this vessel here actually comes right into this little area here and goes into the vein right there. So there's the vein. And then on the other side, this other one also turns out to be, where did it go? This other big guy here is a vein. So rather than being an AVM, this is a veno-veno shunt, and I'll show the angio in a second. But what I think is going on is if we look carefully at the hilum, let's see if I can get a decent window for this. The other thing is these bronchial arteries are big, And if we look at the hilum, you can see the airway is fine. The upper lobe pulmonary artery is open. The superior one is kind of sneaking in here. But if we look at the vein, there's the vein. If we come up, the vein's kind of small up in here, and there are some calcifications right up in here. And so I wonder if this is a very mild form of fibrosing hylitis, like a form of fibrosing mediastinitis, but just localized there. One possibility. And then we have this bronchiectasis. So this is just one run from the angiogram. So they're out in a distal pulmonary artery, and we see the normal branching. And I'll just keep doing it. And then watch, you're going to see that vein start filling. So we're starting to see the veins fill. And there it comes. There's that tortuous vein. It's coming down here, and it's going to eventually work its way back. So there's that veno-veno loop. So it was confirmed to be veno-venous, or veno-venous there. And we've seen some of these before, but I think in this case it was probably acquired. Either there's some subtle stenosis of one of those veins, or maybe from that fibrosing hylitis, or maybe there was just something else going on up there. But I think some of the clues are sort of all these other tortuous vessels, the lack of hypoperfusion, because every big AVM I've ever seen, it's usually very black around it because you're bypassing the capillary bed. And also you usually see this corkscrew artery going right into it, and you could track these back. Just a nice example of not an AVM. And if you could, the MIP's kind of nice just to show that as well. You can
Any splenic calcifications, Jeff?
I don't remember. We don't see, considering everyone we see, it seems to have old histo. The splenic, yes, there are a few in there. Oh yeah, there you go. So yeah, we don't see them all the time as much. I mean, I'd say probably 2/3 of our patients have calcified nodules or lymph nodes, but the splenic calcifications are far fewer, because I think most of the time the infection stopped in the chest. It doesn't even get bloodborne. But you're right, when you have it, it's very helpful to favor old histo.
Cool.
Yep.
I thought this was going to be a wandering vein, but it doesn't wander.
No, it doesn't wander, and I don't think it's congenital. I think it's a pathway that
Right.
just opened.
Yeah.
Because you
I
can
like
see
it.
this whole tangle of veins in here. But had she had her bubble study, they would have seen that there was no shunt, and that would be a sizable shunt. So,
Got it.
yeah. All right. Well, that's all I got. Shrav, did
So
you have
cool.
anything? I see you're on. I'm not sure if you're just observing.
Yeah, I got a couple of cases.
Well, that's great. All right. I'll make you the presenter.
Sorry, hold on. I'm figuring out which monitor to share. Which one is this? I think it's going to be this one. Let's share this. Okay, just to kind of add some related cases to those that have been discussed earlier. This one we can see, history of intra-aortic balloon pump, and then we see like this little radiopaque tip right here. And then we can see lucency next to the radiopaque tip, all the way kind of down here. And then interestingly, there's also some other lucency here. And then if we take a look at this person's left axillary region, it looks like they've got this axillary introducer. So there's an axillary intra-aortic balloon pump. So I guess, and again, since it's kind of getting close to that time when people start taking call, it's important to know a couple of different things about the intra-aortic balloon pump. One is what route was the access? Was it axillary or is it femoral? The other is, there's kinds of two main types of intra-aortic balloon pumps. There's like the large one and the small intra-aortic balloon pump. And so it's kind of hard for us to be, to make recommendations if we don't see the full extent of the intra-aortic balloon pump or know. I think the best way to be able to make a recommendation as to the positioning is to have both the chest and abdomen, basically like know the superior and inferior extents and the markers and where they're located. And patients are, on a spectrum as far as body size goes. And so some patients, a particular size of introducer with marker in a certain location may be acceptable. And in some patients, maybe they're too small for the intra-aortic balloon pump. And even if the marker position is okay, it may end up kind of extending below the level of the renal arteries. And this case kind of brings up an interesting point here. We can see the marker is kind of tilted here, and it looks like it's a kind of curving into the ascending aorta. And another thing that we want to be careful of is using the term advance and retract, because if we use those terms, we should know, what route this balloon pump is, and we should be very confident as to where the balloon pump is going. Is it in kind of in the descending thoracic aorta? There was a couple of years ago a case where a patient had an axillary introducer intra-aortic balloon pump, and we saw the tip, one of the tips here, and the other radiopaque marker was located somewhere over the kind of in this left cardiophrenic region. And I think whoever was interpreting the study recommended advancement, thinking that the other tip was kind of in the descending thoracic aorta, but unfortunately, the tip was actually here in the ascending aorta, and the other tip was kind of in the LVOT, and so the pump was advanced into the left ventricle. So that can produce some not so great outcomes. So a couple of things to be aware of, and really make sure you know where the intra-aortic balloon pump is and where the two markers are before you recommend advancing or retract. That's why I always, on these cases, I just kind of describe where the balloon pump is and have a discussion with the clinician if I think it's malpositioned. And just make sure that we are all on the same page about where it's going.
These are really good points that you're bringing up. So I've stopped saying advance and withdraw in most cases.
Same.
And so what I say is adjusted upward. I would say that this marker could be adjusted upward, meaning up and down in the body axis. Just to be clear, because sometimes I don't know whether it's coming in from the top or from the bottom, coming up from below. In your case right here, I think I'm seeing the distal marker just below that clip right there, right what you're pointing to. And so when these things go into the ascending aorta, we had a case like this about a month ago. It went into the aortic arch and then toward the ascending aorta. And that meant that the balloon was actually folded in there. It was like a hairpin. So you had this balloon going down and then coming back. So it was really looped around, and a whole lot of it was tied up in that aortic arch. So you had some parts of the aorta that had two limbs of the intra-aortic balloon in them. They had to go in and clear this thing up. I think they did some procedure in the cath lab, so I saw a bunch of fluoroscopic images where they were resetting it. So when it goes like this backwards into the aortic arch toward the ascending aorta, you actually have the balloon potentially folded in the lumen.
Yeah.
And so I think that's why the markers are so close together here, because you actually have a big folded component, I think, in the aortic arch.
Yeah, I see. Yeah, it's interesting. And sometimes, there's other sources of lucency in the mediastinum, whether it's like gas in the esophagus or whatever. Right. So just it's good to be sure of what we're, to know what we're looking at. And yeah, the other marker here is what you're talking about.
Right.
So that's one case. The other case that I have is another chest radiograph case. I don't know if somebody, maybe Maya, I'm not sure if Maya's presented this case, but so this patient has this kind of interesting device that looks like an upside down IVC filter, but also it looks like somebody chopped part of an impella and stuck it onto the IVC filter. And so this is an aortic device. And this patient's been enrolled in a clinical trial evaluating this device. And here is a little blurb on, please pardon the all of the trade names and everything, but it's a special type of left ventricular flow augmentation device that basically is situated in the inferior vena cava, and it kind of works similar to an impella where it takes some blood from one end and ejects it out the other end. And so this patient had biventricular failure, and so they received this, this is placed in the descending aorta, and so this helps augment ventricular function. And I think I haven't seen this before. I don't know if anyone else has, but I guess usually it kind of hangs out here in the upper abdomen region.
That's a new one for me.
It's strange that they would put something there because, you know, usually their goal is to improve perfusion of coronary arteries and
Yeah.
the brachiocephalic arteries so that you perfuse the brain. And this device is actually going to suck blood out of the descending aorta and propel it distally. So it's going to be great for legs, but it seems to me it's going to be hard on brains and coronary arteries.
Yeah. I'm not entirely sure what they didn't. I looked through the clinical notes and there was no clarification as to why they chose this over a different device. It just said the patient had been enrolled in this clinical trial for this device. So I will try to figure out why that is. Maybe I'll talk to somebody and let you guys know on the next call if I'm able to find out.
You know, unless the device pulses the way a intra-aortic balloon pulses, then you might be able to get some improved coronary perfusion out of it or something like that.
Right. I mean, judging by the diagram there, it looks like it's continuous flow, but who knows?
Yeah.
I'll check. And then this last case is another sort of cardiac assist device case. I don't recall if I've presented this before, but so this is an LVAD, and so LVADs, we want to make sure the inflow and outflow cannulae are patent. This sometimes you can have orientation of the inflow cannula such that maybe either the interventricular septum or the LV part of the left ventricular wall abuts the inflow cannula and kind of obstructs it. Sometimes you may not be able to appreciate the obstruction on a static CT, and sometimes you can see it on a retrospectively gated CT. Where there's dynamic obstruction of the inflow cannula, and typically that tends to happen when it's sort of more vertically oriented than if it's kind of directed towards the mitral annulus. The other thing on this case is we can see that there's this low attenuation material between the cannula itself and the Gore-Tex tube that surrounds the cannula. And sometimes, you know, it's not as bad in this case, but I've seen cases where the aortic cannula, the outflow cannula looks like a slit. And so this kind of substance, I think, is just old blood products that have accumulated between the Gore-Tex tube and the internal outflow cannula. And so sometimes that can cause pump dysfunction. So those are two areas that we want to look at, the inflow and the outflow cannulas. And the reason that patients have this Gore-Tex tube is because the outflow cannula usually has this sort of L-shaped course, like on the coronal. It comes up and then it kind of takes an acute angle to get to the ascending aorta right here. And to prevent any sort of kinking of the cannula, they place this Gore-Tex tube. This person has a little bit of kind of folding here, but to kind of prevent it from being compressed between the heart and the anterior thoracic wall and prevent that kind of kinking in the cases where it kind of comes up like this and wraps around with a pretty acute angle. That's why the Gore-Tex tube is used. So just some things to watch out for. I think one other random thing, sometimes if you have, sometimes you can see flattening of the left atrium. It can kind of look sucked in and it'll look kind of like a slit. And so when you see that appearance in the setting of an LVAD, that's because the pump setting, the flow rate is too high. And so it produces this sort of like rapid decrease in volume of the left atrium. And so that's some interesting thing that you can see occasionally. That's all the cases I have.
All right, thanks. All
Very
right, well,
cool.
that will be it for today. So good chatting with everyone. Talk again later.
Thank you all.
Thanks.
Thanks,
Have a good
everyone.
one.